Welcome back to Beyond Boundaries, an Action Lab podcast, episode 2, where we will be focusing on violence prevention. I am your co-host, Dr. Kim Baker.
And I'm Dr. Robert Hammerberg. So we've got two fabulous faculty to highlight in our Faculty in Action segment on today's episode. Dr. Brad Cannell, who is an associate professor in our Department of Epidemiology, Human Genetics, and Environmental Sciences. Dr. Cannell is at our Dallas campus, and he is passionate about understanding healthy aging and late life quality of life, and applying that understanding to improving outcomes for older adults. Dr. Cannell also has published research focusing on preserving physical and cognitive function, living and aging with disability, and understanding and preventing elder abuse. Dr. Cannell earned his PhD in epidemiology from the University of Florida, as well as his MPH in epidemiology from the University of Louisville.
Awesome. We also have Dr. Kevin Rix, who is a new assistant professor also at our Dallas campus, where he focuses his work on injury prevention and violence prevention. Dr. Rix also holds a joint faculty position with the Department of Pediatrics at McGovern Medical School. So much of his work is in injury prevention, violence prevention, injury epidemiology. He also has much of his work focused on practice-based research, which is very, very important to the work that we do at the Action Lab. We're interested in policy and practice-informed research. So anytime our faculty, they're doing work that can be translated into actionable steps, we're all for it. So Dr. Rix is also an alum of our institution. He graduated with his PhD in behavioral sciences in 2021. And so we're excited to have him here on this episode as well. So let's get started with the first question. And so our first question we ask all of our guests is, how did you get started in public health? And we really like to kind of talk about it in the way, or framing it, did public health choose you, or did you choose public health? So tell us your entry to public health story. And so Dr. Cannell, we can start with you.
So I got into public health totally by accident. I was actually serving in the Army when my public health journey started. And I was checking out one night at the commissary at Fort Knox. And for those of you that don't know, the commissary is just Army language for grocery store. And in the checkout line, there was like a U.S. News and World Report, and it was said something about, the best careers to get into in the next 10 years or something like that. And I don't remember now. It sure would make a better movie if I just opened up the magazine or the U.S. News and World Report, and the page that I opened to was public health. I don't remember, though. I mean, let's go with that version for now, with the caveat that, I don't know, maybe I thumbed through the whole thing. But regardless, one of the pages in that magazine was public health. And for some reason, it did catch my attention. And I did not have, my background was in political science. I thought I was going to do a 20-year career in the Army. Public health I didn't even know what it was. And so it was quite a departure from my original plan. Being in the Army during 2 wars will do that to you. And then, so I went online, I did a little investigating, thought that it sounded really interesting. And it just turned out that University of Louisville, which was the closest sort of major university to Fort Knox, where I was at, had a brand new Masters of Public Health program. And had a chat with some folks on their admissions team and got the ball rolling. And a year later, I was in an MPH program. And so I guess you could say, I've never thought about it that way, but I guess you could say it chose me.
Awesome. Thank you. Thank you for that story. I would like to see the cinematic version of all of that.
Yeah. You flip open the magazine and the pages glow, and yeah.
Music starts playing.
Yeah.
Dr. Rix, what would you say? Did public health choose you, or you choose it?
No, it chose me. My story is a little bit different than Dr. Cannell's, but so for me, I started my public health journey when I was an undergrad. I went to college originally to be a veterinarian. And unfortunately, the day before my sophomore year, my cat died. And I learned that I couldn't do that for a job, would be to put down animals. So I went to college literally the next day. I was going there to tell my advisor that I was going to change my major. And I walk into his office and he tells me, well, funny enough, my major at the time was called Health and Wellness. That was just the brand name that the major had for anyone who wanted to be pre-med or any of the pre-types. And he told me, well, we actually just became the second bachelor's in public health degree in New York State, where I went to college in Syracuse, New York. And your major is actually disappearing today. So it didn't actually matter because your major was going away today. You are now a bachelor's in public health student. Figure out what you want to do. And I knew nothing about public health at that point. I thought I was going to be a vet, but my health and wellness major became public health overnight without my worries or thoughts or anything about it whatsoever. So then I spent a little time trying to figure out what does that mean, or what am I going to do with a bachelor's degree in public health? And for me, it really kind of hit. I was taking a public health ethics class. And when I was in college, the NFL concussion stuff was really starting to become to the forefront of people's mind. Concussions were not a thing prior to that point. So I had a wonderful professor who said, you like sports, right? And I said, yep. And she's like, well, what do you think about these concussion things? Do you think football is going to exist in 10 years? And I said, of course football is going to exist in 10 years. It's a giant money-making thing. Football is a giant thing. She said, well, how ethically can it exist if we know about these concussion things? I need you to write me a 10-page paper about why football ethically will exist from a public health standpoint. So I did. Spoiler alert, I went to college over 10 years ago, and football is still a thing. So I was right on that end. But from that moment, I just kind of, injury became my thing. Injury became, I worked in a concussion management program at a hospital in upstate New York as my college internship. I went and did my master's in public health and did work in acquired and traumatic brain injury right afterwards. And I just kind of spiraled from that point forward of just all I did and all I wanted to do pretty much from that paper was injury work. And so public health chose me because I had a different major and they changed it on me to a bachelor's degree. So I'm one of the few people who have a bachelor's, master's, and doctorate all from in the public health field.
Wow, it was really, I guess it did choose you. It was like forced upon you, but.
Correct. I was going to go to sports management. That was going to be my backup plan. I was going to go to sports management, and it turned into public health.
So next question, we'd love to learn a little bit more about your work and how you got into violence prevention. You know, Kevin, you just shared a little bit about that too, but if you could share, tell us a little bit more about your journey into that field and share one thing about your current work within that topic area that excites you.
So for me, injury and violence has kind of been my life for the last 12, 13 years now. Prior to enrolling in school, I went, after I finished my master's degree, I went into the professional world. And I went and ran a injury and violence prevention program at a level 1 trauma center in Austin. And my very first project actually at that trauma center was identifying the place that had the most assaults of any place in Austin, and mapping it out and trying to figure out some type of intervention we could do at the location that had the most, we did it by police record, the most assaults going on. Turns out that spot was a bus stop across the street from a fast food establishment. And it was a place where, unfortunately, a lot of drug deals were happening. And when they would go badly, that's when the assaults would happen, or someone would call the police or something like that. So I've been in the violence world, because before that I was doing concussion work and things along those lines. So I started in the violence world in about 2014. Violence has kind of taken me all over the place. So I've done things from that project to trying to improve how a hospital records domestic violence in the emergency room, to teaching people how to control bleeding. And if you've ever heard the Stop the Bleed program, I have taught hundreds of bleeding control as a tertiary prevention metric for how to teach people after traumatic bleeding, how to prevent that from people from dying. And now in my current world, I'm very fortunate to also, in addition to my role here at the School of Public Health, have a role at McGovern Medical School in the Department of Pediatrics. And a lot of the work we're doing over there is on firearms. And firearm is obviously a big hot topic. I just finished my postdoctoral fellowship in Philadelphia, where firearms is a big topic of injury up here. And in Houston, we have a lot of work on keeping children from accessing firearms and accidentally shooting themselves, suicide prevention, and interpersonal violence with firearms. And so a lot of the work that we have going on right now in Houston related to firearms is really interesting to me, because firearms has been underfunded for a very long time. There have been reasons that firearms were not able to be researched for a really, really long time. So because of that, there is a lot of opportunity to work in this field. Granted, it is a very politicized field. There is no way to differentiate or beat around the fact that it is a politicized topic. But from a researcher's perspective and from the research perspective, trying to maintain a neutral perspective of firearms kill people. It was the #1 leading cause of death of children in 2020. So how do we work and develop research projects that reduce some of these issues around firearm violence and other ways of interpersonal violence? Because it's unfortunately become a very encompassing project that we need to work on prevention for.
Thank you for that. And so, Dr. Cannell, What excites you about your current work?
I say that I study healthy aging and late life quality of life. And so when I began my research career, I was really focused on aging, in particular cognitive aging. So how our cognition changes over time as we age, and dementia and prevention of dementia. And then sort of again by accident, late in my PhD program, I fell into a research project that was partly focused on understanding elder abuse and neglect. And so that was really my first foray into injury and violence research. And but it's become a huge part of my research portfolio, and in some ways probably the most interesting part of my research portfolio to me. And so I guess the reasons, when I think about what makes it so exciting to me, sort of echoing what Dr. Rix said about opportunity, there's just elder abuse and neglect. Some of the three of you I'm looking at, or some of our listeners probably don't even know that's a thing. What is that, right? And so, and even among people who do know that it's a thing, very few people are aware of the extent of the problem, and both in terms of how widespread it is and its severity, and therefore there are very few good solutions to the problem right now. And so having an opportunity to work in an area that is largely overlooked by many people and make a difference for people who are largely overlooked by other people, I think is exciting to me. Additionally, in this field, there are a ton of methodological challenges. So how do you even go about studying elder abuse or neglect? So as just one like sort of easy example to understand, right? Let's say that we want to create an intervention to prevent, or maybe it's sort of a tertiary prevention kind of situation, right? Or a secondary prevention, like, so we identify somebody who's living with elder abuse and we want to prevent them from getting ongoing elder abuse. So we come up with this intervention that we think will work. We are mandated to report elder abuse in the state of Texas. Actually, in 49 of the 50 states, you're mandated to report elder abuse. And so if I create an intervention and I give it only to people who have been identified as living with elder abuse, I also have to report them to APS, Adult Protective Services, and Adult Protective Services will do their intervention. And so how do I know when I go look at outcomes for those people if it was my intervention that made the difference or not, or whether it was Adult Protective Services that made the difference or not, right? And so teasing out differential effects of interventions, and so there's like, if we want a comparison group of like a group of people that gets nothing compared to our intervention, it's not possible, right? Unless we break the law, which IRB won't allow us to do.
Thank you all both for that. Just to kind of to respond to what you all just shared about your excitement and both of your individual focus careers. Dr. Rix, you mentioned how the field of firearm and injury prevention had been overlooked for various reasons for a long time. And Dr. Cannell, you're talking about elder neglect and abuse being this overlooked issue. And so for both of those two distinctions, we really want to understand how, if I'm a student and I'm really interested in the gaps and the inequities in both of what you are focusing on in, like, what should I be paying attention to? And so what are the questions that are remaining, particularly anything around disparity? Dr. Cannell, you brought up social factors that may be influencing some outcomes. Like, what is it that a student may need to know about those issues? You can go ahead and start for us, Dr. Rix.
Thank you. I think there's a couple things if I'm so the first thing, to Dr. Cannell's point of just how this topic here. So I consider myself a general injury prevention professional. So my topic areas tend to cover motor vehicles, honestly, is my primary thing, and transportation. But then this violence and firearms also get incorporated. And I think one thing about for the entire injury space is that for a student who's interested in being involved, it is the #1 leading cause of death for people 1 to 44, injury as a whole. So, and most of the time we don't talk about it because we are focused on something that has a long-term effect or things like that, or we think about later in life death or things like that. But if you're interested specifically in younger people and things that unfortunately kill younger people, injury is an area that there's a lot of opportunity to get into. And I think Dr. Baker, to your point of disparities, and one of the things that I think we're really learning is that the easy thing in the firearm world specifically is to draw it down as a Republican Democrat type of thing, where some people are pro firearm, some people are pro or anti-firearm, and it's a Democrat or Republican type of thing. But that's just not enough that's too narrow focused, and it's and I think a lot of times we get really hung up on a lot of the political things that get thrown out there when we're talking about people who are actually injured in these things. It's everybody from every walk of life who, realistically, both Republicans and Democrats want to not have people shot. I think that is they just have different approaches of how they want to do it. So for a student who wants to understand underlying social factors that lead to increased firearm death, because firearm death is a widespread thing, and to understanding community issues that make someone more likely to die of firearms. It's unfortunate fact that African American and Black people die at a higher rate of firearms than their white counterparts. And that number is for a lot of reasons. And some of those underlying conditions are things we can improve, improving the community that they live in, talking to the community members about how they want to see changes happen, and getting out into the field and talking to community members who this impact, and being out there, knowing what they need and what they want for a student. If that is an area that you want to be in and working with those underserved populations, we need more feedback from actual people impacted. One of the projects I'm working on currently right now is trying to understand what messaging is most appropriate for people who own firearms. And we don't want the messaging that we want to deliver to them is not, don't have your firearm. That's just not going to work as a message. We want to understand, okay, if you choose to own your firearm because it is your right to do so, what would make you more likely to? And getting some of those conversations going is something that has been a hard hurdle. But for a student who is interested in working with community members, we need to hear directly from those community members, those underserved populations who we haven't heard their voices enough, and know why they're choosing to own a firearm. What are things that, and even small things, okay, if you choose to own one, are you locking it up when you go home at night? Or are there social reasons why you don't feel safe to lock your firearm up at night? And that is a real issue for people. And understanding some of those things is something that we make assumptions about as academics and people, but we need to hear from the people in the street. And if you're a student who's looking to go and get an MPH, who wants to work in this kind of field, we have projects right now where we're out there talking to people, and that may be an opportunity to help sit in on focus groups, help sit in on community engagement activities, where we ask, okay, this is a topic area that you are impacted by, people are making decisions for you, and we need to hear your voice more often in it.
Okay, so the question was, how do students get involved in this area?
Yeah, and especially if they're interested in addressing the inequities, right? And so what should they know? What are the gaps? What are the major questions that you guys are investigating around inequities?
Yeah, so in elder mistreatment specifically, we have almost all gaps in understanding. There are very few things we understand well. And so basically every dimension of this problem needs talented, passionate people who want to come in and do work. And, one of the upsides of it about elder mistreatment, working with older adults, late life quality of life, caregiving, one of the upsides to that being maybe not as high on the radar as some other topics is that if you're a student looking to make an impact, you might have less competition in terms of, the number of people who are interested in that area than if you do choose something that tends to get more headlines in the media or something like that. Although firearms is probably getting a lot of headlines in the media recently. But for elder mistreatment specifically, I think we are always talking about how we need more people and how we can get more people involved at every level: students, junior faculty, postdocs, established people who want to transition what they've learned in their area of research over to elder mistreatment. I mean, at all levels, we need talented, passionate people. So there's plenty of opportunity to get involved. And I don't think we publicize it well enough, but there are scholarship, training, and mentoring programs available that I can connect people with if they're interested. And I assume that my contact information will be available somewhere. Thinking about disparities specifically, for elder mistreatment, disparities are poorly understood at every level. So disparities, I'm thinking now in terms of mostly racial and ethnic disparities, but it could be sexual and gender minorities. It could be regional disparities. It could be disparities based on age. Those disparities are fairly poorly understood, even to things as fundamental as defining what constitutes elder mistreatment. So things like that, just in terms of like, how do we define elder mistreatment? How do we detect elder mistreatment? There could be huge differences, cultural variation, racial variation, all kinds of other variation that we frankly don't do a very good job of accounting for right now.
I'm curious to that point. You had me thinking. I'm just thinking, personally, the personal and the professional, right? And so I'm putting on my kind of upstream hat and thinking about some systemic inequities in terms of like, so my mom stays with me, although she's in her 70s, I still don't consider her an elder, but I think about access for our parents to say in living conditions that are environmentally safe. And in terms of like any differences in zip codes and like the people that work there, like, do those things come up in your research in terms of the workforce of people who care for the elder population and some differences there? Just interested. This is like you said, this is such a topic that I think doesn't get enough attention.
So one thing that definitely comes up is it's pretty clear that there are cultural differences, regional differences, and the expectation for how much care a family will provide for other family members as they age. In some places, it's common for people as they age to have a lot of family or some sort of immediate social network that will provide assistance to them, that will help them age more successfully and age in the community that they grew up in, or that the community they're living in, versus having to be moved into some sort of assisted living situation. And I think that there's quite a bit of research showing that there are cultural, racial, ethnic background differences in terms of who is more likely to have that kind of social network around them, and what the expectations of people in that social network are very different as well.
I guess, given you the opportunity to succinctly kind of get a message across about, from your perspective, what do we, the collective we, either that's the communities with which you work in, the state with which we live, or us as a society, what do we need to do to go beyond traditional public health and transform the work that you all are doing? What needs to happen there?
The first thing is, to your point of that, the injury and violence prevention world is super broad. And it is, nobody wakes up any given day and says, I'm going to get hurt today. That is never a thought process that goes through somebody's mind. It's what I think about every single day, is that I wake up and somebody out there is going to get hurt today. And I think the first thing for this topic area is bringing that level of consciousness up, in that none of us are immune to being hurt any given day of the week. We can all wake up and fall down the stairs, or get into a car crash, or unfortunately get shot or get punched, or a lot of different things can hurt you. And to me, while it's not nice to think about, stream of consciousness of injury is a looming thing that may exist, is the first thing that I would like to see change, just because we don't think about injury until it's too late. Our healthcare systems are built around treating people, not preventing them from ever getting in there. When I worked in the hospital, my running joke, that wasn't actually a joke, was, if I do my job perfectly, we all go out of business tomorrow, because we stop having patients. And I think one of the things that, to shifting the culture of how we focus on stuff, is understanding that prevention is cost saving and not just spending. And I think a lot of times in the healthcare world, there are a lot of people out there who don't look at the prevention person with as much grace as they do the clinician who treats somebody for their broken leg. Where if I keep them from having a broken leg in the first place, then that's better. The other thing I'd always say was, I want you to picture your favorite person in the world. You get two choices. They either get the best care they've ever had at the hospital, or they never have to go to the hospital at all. You get to choose now. And most people will pick the never go to the hospital in the first place. So shifting how we talk about injury and violence as a prevention should be our focus, not just treating people for injury. We put a lot of money into things like trauma centers and great physicians, and not saying those aren't important. We need them. We're not going to prevent every injury every given day of the week. But shifting that we put more of an emphasis on the prevention aspect of it than the reliance on clinical care in the background. The United States, unfortunately, does really poorly. And if we can think outside the box of how we incorporate more prevention work that keeps people out of the hospital, keeps people doing whatever they love to do, however they love to do it, that there's a lot of work that needs to be done in making that more of the way we talk about this topic area in the first place.
I think thinking about elder mistreatment specifically, something that I often tell people when I'm talking to them is, I think ageism is an important component that maybe doesn't cause in and of itself elder mistreatment, but creates an environment where elder mistreatment is more likely to occur and or be tolerated. Recognizing the importance of ageism as an ism and as a tool that is used to other people and belittle people and create the perception that some people have less value than others. I don't think it's taken seriously, and I don't think it's appreciated, and I think we could do more on that front.
Thank you all both for those answers on how we transform public health to meet the needs and the gaps that you all shared here today. Are there any final things? Is there something that you guys are thinking, they didn't ask me this, but I wish they really would have asked me this? Do you want to share anything else in that light?
I would have one thing to add, just really quick. And so for all the students who may be listening out there, so I'm new to the university as a faculty member, and we have a lot of upcoming projects in the injury and violence prevention space. So if injury and violence is something that you really have never thought about, or something you potentially wanted to get interested in, that is my area of where I'm coming in to try to expand our work. So for any student who who's looked through a catalog and said, hey, I wonder if there's anything on assaults or violence or car crashes, there are opportunities for you to get involved. And as Dr. Cannell mentioned, our contact information is available. Get a hold of us. We want to work with you. I'm a proud UTHealth alum, and I want more UTHealth alums to like this kind of topic work. So if you're interested, please reach out. I had many UTHealth master students come work with me at the hospital. So anyone looking for internships in the injury world, I got a lot of places to send you if you're interested in places you're interested in going. If you want to work in a hospital or in injury world.
Awesome. Thank you all so much.
We also have an alum that we're highlighting. Yep. So actually we're kind of getting the 2 for 1. We have 2 alum that we're highlighting in this episode. And so Dr. Katelyn Jetelina, she is an alum of our institution. So she has done some fabulous work talking about practice-based, right? So the work that she's doing with Your Local Epidemiologist and how that has taken off, thousands of people learning from how she's translating evidence and science into layman's terms and having people understand exactly what public health can do. We're super excited for you all to hear from her as well.
Yeah. Thank you so much for participating in our episode focused on violence prevention. And so our first question to you, Dr. Jetelina, is how did you get started in public health? And the question that we ask everybody is, did you choose public health or did public health choose you?
Oh, it for sure chose me. That's a good question. I actually always thought I was going to be a MD, a doctor. And so a physician. So I was pre-med in undergrad, and then I took a year off, worked over in South Africa in the HIV and AIDS townships, and decided to take 1 year off and do public health, whatever that meant at the time to me. Then I still thought I was going to go get my MD after my MPH, but really wanted to keep digging deeper. And so I pursued my PhD and never really looked back. I think one really big difference that I saw between clinician and public health was that clinicians are super important, right? Because they help treat people one-on-one. But the really sexy thing to me about public health was that you could treat millions at a time. And the impact of that is huge. And so it really hooked me. And like you said, I think that public health chose me because I was actively resisting for a very long time.
Awesome. Thank you for that. And it's good to know that that is the sexy part of public health that sticks out. I love that. I absolutely love that. And so, our next question, and I'm just going to put this in context of how I came to just learn about your work. I'm going to tell you, Katelyn, during COVID, when things were insane, and you putting out so much information for the critical mass of folk, and you had folk talking about public health and learning what an epidemiologist was. It was so fascinating. I would share your posts with family and friends, no, y'all, look at this. No, this breaks it down. And so that impact on millions right there, that was very sexy. I'm like, yeah, now you know what public health is, and now you know why this is important. So thank you for sharing that. And this leads us to the next question about kind of what you're doing currently, right? What excites you about what you're doing currently, right? And what was it from kind of those moments that you were cranking that out? Mind you, y'all, she's a mother of young folk, of little ones. And so a lot of this, she was doing it as a mother of little ones. And so tell us what excites you about your work right now.
Yeah, I like you said, we were all thrown into this all hands on deck response of COVID-19, and I kind of just found a little space that wasn't being addressed around the world around scientific communication and processing the infodemic, just overabundance of information, so people could feel empowered to make evidence-based decisions. And and my experience with COVID completely changed my trajectory, completely changed and showed me what I loved about public health. And right now, what I'm doing is I'm not in academia anymore, sadly. I moved to San Diego to be closer to family and friends, which was very difficult to do, leaving UTHealth. But that provided me a lot of opportunity at the same time to work in policy, to work in consulting, and to work in scientific communication as an epidemiologist. And there's really no space for what I'm finding is there's no space for this, that I'm kind of creating this space, which is risky. It is also scary, but it also is very exciting and a lot of fun. And I think it's much more needed that if we want to make a big difference with public health, we need to be able to better communicate our invisible work and talk to policymakers even and better. And so yeah, I'm exploring and also taking a few months off because it has been an exhausting sprint over the past 3.5 years, and really enjoying my time just hanging at the beach and sleeping and reading a book or two.
That's great. It's so well deserved because, my gosh, yeah, there has been nobody that has been cranking out information that I've seen in the way that you have, like you have. So and I guarantee that took so much of your bandwidth and time, or on top of your personal life and everything like that. So yes, but I hope you're enjoying the beach. And as you mentioned, you're in this place of creating this space and exploring this field even further. When you get back to it and you're thinking about it with a fresh perspective, what ways can I get involved if I was a student and wanted to learn more about what you're doing or how I can help, or what maybe actions I can take? What advice would you have?
I think the biggest advice I have for public health students and also as scientists is that we really need to integrate scientific communication as a hard skill in our training, and not see it as this, oh, that would be nice, but it's absolutely critical. So whether that means you're talking to family and friends, whether that means you just finished a research project and you want to put together, and you should put together an executive summary or an infographic, or if you're working on something in policy and want to create a research brief, as scientists and as trainees, we're trained very well to talk to other scientists, and what we're not trained well is to talk to the public, or talk to stakeholders, or talk to our research participants, and we really need to get better at closing that loop. And so my advice is try and get training wherever you can. University of Texas in Austin has an amazing comms department that I hope one day will be better integrated within UTHealth School of Public Health. But in the meantime, practice. It all takes practice. Yeah, training in classrooms can be good, but not until it's a different thing if you go on a Canva and just try and create an infographic. So it takes a lot of practice.
Knowing from your perspective, like, what do you think it takes to transform public health as we know it, right? To get it to where it needs to be. And you can answer this in the context of the work that you're doing now, and maybe specifically to injury prevention and violence prevention as well. So what would you say, whether at a city level, regional level, state, national, global, however you want to take it, like, what's necessary to transform public health?
Oh my goodness, there's a lot. I think one thing we learned during the pandemic, but like you alluded to, public health is beyond infectious diseases and beyond a pandemic, is that When public health works, it's invisible. And I think for a very long time, public health has been very much okay working in the background. But given how much public health is integrated within our politics, it's really important for us to show when public health works, to show what is a public health problem, and to show what it means to be in public health and to gain that trust back and to really work with communities. And like I said, that's beyond, and to me, that's naturally scientific communication or knowledge translation, but that can look at like very different things depending on if you're in health behavior or in policy or in epi. And I think that we're doing ourselves a disservice if we can't talk about risk communication, if we can't talk about what is, prevention, and show people that, because when we can show how important public health is, that it touches on violence prevention, it touches on climate change, it touches on reproductive health, literally everything in the news today, then there's going to be more support for it. There's going to be more funding. But if people can't see it, then that's a really big challenge. And I think it's been a demise of public health for decades. So that's what at least I'm trying to do, is trying to showcase, trying to show how we learn from communities as much as communities learn from us, and try and build that trust back up with time.
Yeah, thank you for that. And thinking about the communities that you speak of, you're part of, the three of us are part of the alumni community at UTHealth Houston School of Public Health. We're a double alum. And I'm curious too, how that community has maybe influenced or integrated into the communication work that you're doing. I'm wondering if, when you're sending out some of those communications, if you're getting some connections with previous grads or other alums that want to get involved in your work or share what they're doing or something of the sort.
Oh yeah, I mean, just I went to the UTHealth graduation when was that? A month or two ago now, and the amount of emails I got from recent graduates and other faculty saying, "Katelyn, I can't believe your newsletter. Like, I would love to share this research." I mean, it's, and I want it to be, I see my newsletter as being a mouthpiece for public health, and public health goes beyond Dr. Jetelina. Like, there's no way I could ever cover all public health. And so I think that the alumni, the greater public health community, my students have been an integral part in the newsletter, and also giving ideas of where it should be and where it should be going. So it's an incredible community, and I hope that I can integrate the work even more going forward. Yeah, I mean, I think we didn't touch on violence prevention, but I think the really important thing going forward, and my goal, is to show that public health touches on all of our lives beyond a pandemic and beyond an emergency, right? And when I was at UTHealth, I was starting a violence prevention research lab, and a lot of people don't realize that, for example, gun violence and domestic abuse and child abuse touches on public health as well. And if we can find patterns, that means that it's predictable, and if it's predictable, that means it's preventable. And so I hope that we can continue to show that public health is much bigger than infectious diseases. And in fact, if we don't address, and we call them social determinants of health, then even our infectious diseases will kill more and more people going forward. And so I guess that's the only thing I have to say about that. But if you're a student, my biggest advice is to take as many eclectic electives you can take. Take nutritional epi, take violence epi, take all of these, mental health epi. I remember taking as a student, because it broadens your perspective so much. And what you'll find is that all of these topics overlap with each other. and really describe the one health that is public health. So have fun while exploring. I'm quite jealous of students right now because I think I always enjoy learning new things.
You brought up social determinants, and I'm curious, is there any one particular social determinant that you're interested in exploring more or sharing that data more, digging deep into and tracking?
So I consider myself an epidemiologist, but also a data scientist. And one thing that I've loved working on is figuring out how to connect health systems, so the electronic health records, with a larger perspective of the patient, right? Is that patient homeless? Are they having trouble getting food? Do they need certain transportation? Because I think there's this statistic that 60% of medical outcomes in the hospital are not dependent on the diagnosis, but it's dependent on these social determinants, right? Like if you cannot pay for food, you're not going to pay for medicine. And so one really exciting thing that's happening in data science right now is how do you connect the health system with the local food bank, with the homeless shelter, with all of these different domestic violence shelter. And so when a patient goes to, for example, a food bank, then that food bank will have an understanding of maybe what type of nutrition they need because of these health outcomes. And when they'll go to the hospital, they'll know they went to the food bank. And so all of these systems start talking to each other. And when we start treating people in a 360-degree perspective, then the hope is that we'll have a healthier society. And so it'll be really interesting to see what happens with those data systems and, for example, with AI. And can we be very innovative and cutting edge in public health and create public-private partnerships so we ultimately improve our community health is something I'm very much looking forward to going in the future.
Your newsletter was primarily focused on COVID-19 during the height of the pandemic, but has now shifted to include other relevant public health topics and work. And so I'm just curious about your experience communicating information about varying public health topics, and specifically thinking about injury and violence prevention and gun violence and some of the other actions that you mentioned. How has communicating that information differed from communicating information about COVID? And do you need to communicate it in a different way through your newsletter for it to be more easily received? I'm just curious about that.
Yeah, that's an interesting question. So I have been the past year-ish been trying to show people again that public health touches on our lives in different ways. And one of them is I've been talking about is gun violence. What I've noticed, just like with COVID, is that scientific communication around that has to be apolitical. It has to be, which is challenging to do in public health if you want people to listen. What I found also is that scientific communication is different than advocacy. And so when you combine those two things, people will see through it and stop listening. I found that we have to stay relevant in public health. And that means, at least with my newsletter, is writing news waves. So something comes out and I am typing as fast as I can, or finding the expert that can talk about this as fast as it can, because it needs to be relevant and it needs to be actionable. And if you do not have those two things, may be interesting, but it won't be helpful to people at that time that want to feel like they need to do something, feel like they need to change some sort of behavior, and you catch them in that window. So it's been a wild ride, and it's been a fun experiment because I get to see on the back end the metrics on how things differ with my COVID posts versus gun violence versus reproductive health versus whatever else we're talking about. And so it's been a pure experiment to see if I can sustain interest. And I think I'm doing so far so good, but we'll see as this continues on, and if we can make it more of a sustainable model.
Awesome. And question, are you still collaborating with any faculty at UTHealth, or are there opportunities for that as well with what you're doing?
I collaborate. I guess it's your definition of collaborate. Like, I meet with Bijal, I talk with her all the time. We talk about, I'm working with Brad Cannell on a few projects. So it's here and there. It's more because they're just awesome people, and we're friends now rather than in the professional space. But yeah, my door is always open, and I hope that I can help UTHealth along the way with integrating and strengthening SciComm as we go. But awesome. We'll see.
Awesome.
All right. Well, I think that's all we have. And thanks again so much for participating.
Yeah, thank you.
Well, thank you so much for joining us today and listening or viewing our podcast. We hope you enjoyed today's episode. If you haven't already, our first episode is published also on our Spotify account, so be sure to give that a listen. And we look forward to having you listen in our future episodes.
Absolutely. And so episode 1 was on community, episode 2 on violence. And so stay connected, tune in, share with as many people as you like as we continue to explore other topics from Public Health Week 2023.
Yeah.